heart diseases in refugees. I'm a pediatric cardiologist from Greece, and I will present two cases which I believe help illustrate my topic, and then I will talk to you about a literature review I have conducted on that neglected topic as well. So first of all, we have the first case. He's a 3-year-old boy. He was born in Somalia. He arrived in Greece on June 2024, and initially he arrived in Samos, which is one of the islands of the Eastern Aegean, and people cross with boats from Turkey. So he was referred from the local hospital for a lower respiratory tract infection and a history of complex congenital heart disease. And that is his chest X-ray. So we can see a cardiomegaly, and we can also see bilateral shadowing of both lung fields as per LRTI. So we performed an echo to elucidate the congenital heart disease, which was really interesting. So first of all, there was one very large ventricle and a very rudimentary ventricle on the right side, and the child had good contractility. There was also an enlarged sinus venosus and one big atrium. The arteries were malpositioned, the two greater arteries were malpositioned, and the pulmonary artery was stenosed with a pressure gradient of 55 millimeters of mercury. So we decided to do a catheterization to further elucidate the pathology of the congenital heart disease. And that is his catheterization. So you can see the dye going to the left ventricle. And he actually had bilateral SVCs, and that is the left SVC. That is the cause of the large coronary sinus. So the results of the catheterization were actually double inlet and double outlet right ventricle with a very small rudimentary, almost aplastic left ventricle, with which it communicates by a wide interventricular septum. So functionally univentricular heart. So the single right ventricle is dilated and trabecular, but with a good contractility. There was a malpositioning of the great vessels and some mild to severe moderate valvular stenosis of the pulmonary artery. There was marked dilatation of the pulmonary trunk and peripheral pulmonary arteries, normal outflow of the pulmonary veins into the left atrium. The pressures were increased initially, but the pulmonary resistance with the wedge pressure in the peripheral pulmonary circulation was normal. There was a persistent left SVC draining to a dilated coronary sinus. So afterwards, we had our multidisciplinary meeting on what to do with that child. So he had borderline SATs, but he appeared to be quite well, with some mild dyspnea on exertion, but overall a good quality of life and appropriate height and weight, despite all his hardships being a refugee. So the decision, since it was a neglected congenital heart disease, was to undergo a PA, pulmonary artery banding, and after 6 months repeat the cath and perhaps arrange for a possible Glenn shunt. So he underwent a pulmonary artery banding, and post-op he had increased pulmonary artery pressure of 85 millimeters of mercury. So it was quite a tight banding, but as we mentioned earlier, it was a balanced circulation with the initial pulmonary artery gradient of 55 millimeters of mercury. And that is the post-op. So you can actually see the tricuspid regurgitation and good contractility. However, he had problems with recurrent infections. And as a matter of fact, we actually performed TB testing on him. On his, it was negative, but mother was positive. She had a positive tuberculin test, but it was negative for him. So, in order to further elucidate, we had an IGRA which was negative for the child. So, for the treatment for mother's latent TB, in the children we would treat, but after discussing with the adult pulmonologists, they decided that for latent TB in adults with a clear not cavitating chest x-ray, we would actually wait and watch. So the case 2 is another child. He was also referred from a camp in Athens, and he is 5 years old, but one very striking feature about him is that he is very, very small. So his height is 85 centimeters, less than the third centile, and the weight is 8.5 kilograms, again less than the third centile. So he was profoundly cyanotic with clubbing. His heart rate was 100 per minute, SATs were 65% in air. From his past medical history, there was also a prematurity. He was a 26-weeker with a birth weight of about 1,000 grams, and he was born in Turkey. But initially, his family, they are refugees from Afghanistan. So he was known, actually, that is a very common condition and a very characteristic condition. So he has been diagnosed from Turkey with phallotetralogy, and it was also difficult for him to have a good oral intake. So that might have been the explanation for his short stature. So that is the post op. Initially, we did a CT scan to elucidate the anatomy and also to look for collaterals. And unfortunately, the CT scan was equivocal for collaterals. So he undertook a catheterization, a diagnostic catheterization, which confirmed the diagnosis of tetralogy of Fallot, right heart, right-sided aortic arch. And also we tried to do a pulmonary valvuloplasty, but with limited success. So after that, he underwent a full repair. There was some discussion because of his poor condition, of his extremely low birth weight, of the history of neglected congenital heart disease, whether we should go straightly for an operation, a full repair, or we should rather go for a BT shunt first. But decision was done to undertake a full repair. So that's him as well. And as we can see that he's got pulmonary regurgitation. He also had tricuspid regurgitation, that is the pulmonary regurgitation, some very mild pulmonary stenosis remaining, but he also had some tricuspid, severe tricuspid regurgitation, decreased contractility of the right ventricle, and he also had tricuspid regurgitation, severe, and right atrial and right ventricular dilatation. So subsequently, when he was in the ITU post-op, he did develop liver failure and renal failure. He required inotropes for a long time, and he did improve with his liver failure being reversed and also the renal failure being reversed. However, due to him having been intubated for almost 2 months, he had to have a tracheotomy. So when he came back to the cardiology department after his lengthy stay in the PICU, we were quite concerned because his oral intake was very, very poor. So we started to look into the causes of his poor oral intake. So he had a pH study and a fluoroscopy, which demonstrated severe acid reflux. That's why afterward we decided to perform a gastrostomy with an NG tube. Subsequently, unfortunately, he developed a ruptured gut, and he needed to have a repeat operation a few days after that. After that, he remained well, and subsequently we managed to close his tracheostomy. So he remains in a good saturation, getting stronger every day, and we eventually discharged him back to his camp with his family, but with a gastrostomy tube, and he's being fed from his gastrostomy. So these were my two cases. I tried to conduct literature search for the neglected congenital heart disease in refugees. However, it was difficult to find relevant articles. So we know that congenital heart disease, however, is the most common cause of major congenital anomalies. It represents a major global health problem, with 28% of all major congenital anomalies consisting of heart defects. The reported birth prevalence of congenital heart disease widely varies among studies worldwide. There is the estimate of 8 per 1,000 live births has been accepted as the best approximation. So the first study I looked into is the birth prevalence of congenital heart disease worldwide, where they did a huge literature search of papers. And overall, the reported congenital heart disease birth prevalence increased from 0.6 per 1,000 in 1930 to 9.1 per 1,000 in 1995. And while the worldwide annual birth rate is around 150 million births, this corresponds to 1.3 million births of children with congenital heart disease every year, which is a major public health issue. So the increase over time is S-shaped, and eventually it stabilizes for the past 15 years. So that is how the increase about the birth prevalence of congenital heart disease, and it probably reflects the increase in prenatal and postnatal detection. Apart from time, also significant geographical differences were found. The highest reported total congenital heart disease birth prevalence was found in Asia, 9.3 per 1,000 live births, and the lowest in Africa, 1.9 per 1,000 live births. Reportedly, total congenital heart disease birth prevalence in Asia was higher compared with all other continents. However, Europe had the second highest reported total congenital heart disease prevalence, and one potential cause could be the increased rates of consanguinity in some Asian countries. So these are the total birth prevalence of various congenital heart diseases like VSD, ASD, PDA, pulmonary stenosis, tetralogy of Fallot, etc., in all the continents, being more prevalent in Asia. For some reason, everything is more prevalent in Asia. So regarding the global burden of disease, it is estimated that 250,000 people worldwide die from congenital heart disease every year, and out of 1.35 million new congenital heart disease births annually. In the United States alone, there are 2.54 million individuals living with congenital heart disease. According to the Global Burden of Disease, in 2017, about 180,000 births due to congenital heart disease, 69% of all congenital heart disease, occurred in infants under 1 year of age. So that is again from the study on the global burden of disease. In 2021, the global prevalent cases of congenital heart disease in children were 4 million, and a little bit more than 4 million. And from 1990 to 2021, the global prevalent cases of childhood congenital heart disease increased by 3.5%. However, accordingly, the prevalence rate increased up to 652.4%. In 2021, all 5 regions experienced declines in the congenital heart disease associated mortality, and the low index region reported the highest number of deaths with 80,000 cases, while the high index region had the lowest mortality with 3,638 deaths. The high middle SDI region saw the most significant reduction in congenital heart disease associated mortality with a decrease of 85%. The low SDI region had the highest rate of congenital heart disease deaths of 48.7 per 10,000 people, whereas, as expected, the high SDI region had the lowest with 6.8 per 10,000 people. And that is again the schematic of the mortality which is highest in the low SDI regions and etc. So regarding the mortality in 2021, South Asia had the highest number of congenital heart disease associated deaths, and Oceania had the highest mortality rate and the smallest decrease in the childhood associated mortality rate. In East Asia had the largest decrease. As noted previously, the global SDI was 0.67. 9 regions had higher childhood associated mortality rates than the global mean, whereas 12 regions had lower mortality rates than the global mean. And again, that is the mortality schematically. We can see the red color with the higher mortality and blue color with significantly decreased mortality. So, regarding some studies that specifically looked at neglected congenital heart disease in refugees, there are not that many studies, like mentioned before. So, one study is regarding the Syrian patients, who were referred to the Children's Heart Center at the American University of Beirut in Lebanon between the years 2012 and 2017. That is a retrospective study of the charge of 439 children. The mean age at presentation was 3.97 years, and 205 patients were females. 99.22% were found to have no heart disease, 15.7% had simple lesions, 33.3% had moderate, and 28.5% had complex congenital heart disease. Patients underwent interventional procedures with a surgical mortality of 10.1%, which was compared to 2.9% of the local children. The average cost per surgical procedure was $15,000. So the study concluded that congenital heart disease poses a significant health and financial burden on Syrian refugee population in Lebanon, and the Syrian cohort had a higher frequency of complex congenital heart disease with additional comorbidities and that was their explanation why they had a higher surgical mortality rate. So that is another study, again on Syrian refugee children who were referred to the cardiology department in Jordan. And it was from April 1, 2012 to April 30, 2014. In it was 119 children with a median age of 2 years who were diagnosed with heart disease. At presentation, 37% had failure to thrive, 13% had severe complications, and 32 of cyanotic patients had severe hypoxia with oxygen sats less than 70%. And their mortality rate was 14%, which is similar to the 10% from the previous paper. The funding from procedures came from multiple outsources, including the United Nations, government, NGOs, and donations. And again, like the previous case, late presentation and diagnosis, high rate of complication, suboptimal management of conditions, lack of funding, shortage of specialized centers, high mortality rates are among the major challenges in refugee populations. So this is another paper from Iraq this time, and it mentions the collaborative partnership between a local government hospital and international private organization trying to establish a high-quality pediatric cardiac surgery program in Iraq. It was from 2021 until 2022. 144 patients underwent 148 procedures. Infants were the majority, 58% of the patients. The most common anomalies included tetralogy of Fallot, VSD, and various single ventricle categories. And the overall surgical mortality rate was 4.1%. But there was no significant difference between our observations of surgical mortality in category 2, 3, and 4 and those expected from the ACTS database. But I would say that is more for a short-term follow-up. And again, these are all the conditions they had. They had boys and girls, mostly 71% girls. Most were infants, 49% less than 6 months. Actually 34% less than 6 months and 41% more than a year. A substantial proportion, 21%, was less than 5 kilograms, and the most common condition was VSD. So, to summarize, in low and middle income countries, children with congenital heart disease are at risk of developing complications related to the scarcity and non-existence of surgical and interventional services, delayed diagnosis, insufficient caregiver education, financial constraints, difficulty reaching treatment centers, sociocultural stigma, and sex-based discrimination. In addition, the lack of hospital resources and workforce, the need for prolonged hospitalization and strained physician-patient relationships contribute significantly to delayed intervention, hence complications. The WHO estimate suggests that 90% of these children have suboptimal or no access to cardiac care at all, due to the fact that most of the children are concentrated in low and middle income countries. Now, over 85 to 90% of babies born with a congenital heart disease now live at least age to 18-20 years. However, although the survival looks high, they do face a lifelong struggle with problems like growth, eating, developmental problems, exercise intolerance, heart rhythm, heart failure, cardiac arrest, or stroke. So that is another study from 380 medical records of children, that is from Ethiopia, who were seen from 21 to 2024, and 46 of the children were female. the main age was 28.4 months, with a median 9 months. Cyanotic congenital heart disease was 70%, 30% was cyanotic. The most common congenital heart defect was isolated VSD. And as for cyanotic, as well known, tetralogy of Fallot is the most common cyanotic congenital heart disease. Suspected genetic syndromic abnormalities were detected in 27%, and critical and non-critical comprise 71% of all children. And that is all the results together. Like we mentioned, the most common is VSD and tetralogy of Fallot. 70% of children with congenital heart disease experienced at least one complication, making 68 and 77% of children with unoperated acyanotic and cyanotic congenital heart disease experience at least one complication. The most common complication was wasting at 4.5%, congestive heart failure, recurrent respiratory tract infection, and pulmonary hypertension. However, wasting is more common in children with cyanotic congenital heart disease than in acyanotic. And again, I don't know if you can see it, these are all the results of the children and their complications they face, like wasting and failure to thrive, associated with other chromosomal problems like trisomy 21 and other neurodevelopmental delay and other problems. And also, these are the complications as per isolated defect. So you can see that in most complex congenital heart disease, we also have more complications. So, conclusions: we live in a world subject to rapid globalization, affecting low and middle income countries, and amid the epidemiological transition occurring, by which infectious diseases gradually decline. However, non-communicable diseases rapidly increased. Low and middle-income countries are faced with a double burden of cardiovascular disease. 18 million people die every year, of which the majority, 4 in 5, takes place in low and middle-income countries. Rheumatic heart disease is a disease of poverty. However, people forget that it's not the only one. As a total of 93% of the population does not have access to cardiac, surgical, or interventional care, that equals 6 billion people living without basic access to care. There are 4 categories, like geographical barriers, infrastructural limitations, poor quality of care, and financial barriers. However, there is a myth and a reality, and the myth could be that there is no role for cardiac surgery, or cardiac surgery is recommended, cannot be scaled, that cardiac surgery or interventional cardiology is a luxury. Cardiac surgery and interventional cardiology is not possible in the setting of poverty. Cardiac surgery is instead more specialized of an intervention. But these are all myths, and the reality is that cardiac and surgical and interventional cardiac services can and should be set up in countries. So suggestions would be this: data collection, infrastructural development, capacity building, regulation of NGO and foreign aid, and universal health coverage. So to summarize, we presented 2 very important cases that help illustrate the problems that refugee populations face. And we hope that this would be a priority that aligns with the 2030 WHO fight for the elimination of non-communicable heart diseases. Thank you very much.
Dr. Agnostopoulos, thank you very much for the wonderful presentation, for highlighting the problem in middle and low-income countries. for your dedication to the children, to the health of children, and for doing your best to help each child to have access for the appropriate, correct medicine as it should be. We are online with? We can have some.
Yes, thank you.
Very welcome.
Thank you very much for your attendance and very good presentation covering all the aspects. It's true that, all this migration process regarding, the sick children of these refugees is an additional risk factor, especially. And there is also, it's not only, the congenital heart defect, but there is also, we have to enter into a holistic approach and try also to cover psychologically the families of these sick children. I don't know if in Greece, especially, in the public hospitals, there is this kind of structures providing also psychological support to these refugee families.
Great question, Prof. Kalangos. So in my hospital, we do have a psychology service for inpatients. There is a separate one for the oncology patients, but we have a service for all patients. However, more often than not, the language barrier is a problem. So we used to have, at the height of the refugee crisis, interpreters for Farsi and Arabic. However, this is no longer the case. So we would have to rely on either the Red Cross or some charities to provide this translation service. And we do also have the social services, but after they leave from us, they would have to go back to, usually they live at a camp. Again, at the refugee crisis, we used to have apartments where they could be placed in, but now it is mostly the camps which are run by the government. So I would say the language barrier poses the most important barrier to communicating and providing a proper psychological support service.
Thank you very much, and happy to meet you on the screen. Thank you.
Thank you.
Thank
Thank
you.
you.
Thank you very
My
much
honor.
for joining in Congress.